when we're talking about cardiac support, almost all of them are in some form of shock, which is why they need cardiac support. So let me ask you this, and those of you who know me probably have heard me say this before, but what is the simplest definition of shock?
Inadequate tissue perfusion.
Inadequate tissue perfusion? That's not a bad definition.
Poor cellular uptake.
Poor what?
Poor cellular uptake of nutrients. Yeah, that's
Poor cell uptake of nutrients? That's also not bad. Is there an even more fundamental definition?
The body's response to a sudden drop in blood pressure.
Demand greater than supply, sudden drop in blood pressure. All of them not wrong.
Not adequate for life.
Not adequate for life. So my favorite definition of shock is hypoxia at the cellular level. 5 words. Hypoxia at the cellular level. That is the best definition of shock. If you don't believe me, think about the 4 broad classes of shock. We have cardiogenic shock, right? We have obstructive shock. We have hypovolemic shock. We have distributive shock. But at the end, the final common pathway is the cell is not getting oxygen. Now, cardiogenic shock, that just means shock is because of what problem? The heart. The heart is the cause of it. The heart is, there's something wrong with the heart. How about obstructive shock? Give me an example of that. A PE. What else? Tension pneumo. Pericardial tamponade. Very good. Give me an example of hypovolemic. Sorry, what? Bleed. GI bleed, right?
Diarrhea.
Diarrhea. Okay, that's really bad if you're in shock because of diarrhea. Okay. Don't eat that next time. Okay? Distributive. What is the most common cause of distributive shock? Anaphylaxis. Right? Anaphylactic shock is the most common subtype of distributive shock. So, but what you'll notice is that whether it's anaphylaxis, sepsis, diarrhea, GI bleed, pericardial tamponade, whatever, cardiogenic shock, what happens is the cell does not get enough oxygen. Probably most working medics, certainly paramedic students, a lot of people still, a lot of healthcare practitioners still want to jump to, well, it's persistent hypotension or hypoperfusion. But can you give me an example of someone who's got a blood pressure that is fine, but their cells are suffocating? In fact, they may look warm and well perfused. That's one. What's a common one in the fire service? CO poisoning, right? So you can't, so those other definitions don't always work. They may be actually well perfused. They may actually have a blood pressure that's decent. They may be warm, warm red skin, but they're suffocating. So hypoxia at the cellular level really is the most fundamental definition of shock. Today, however, we are focusing on cardiogenic shock because we are talking about cardiac emergencies for this module. And cardiogenic shock simply means a problem with the heart is causing hypoxia at the cellular level. So one of the things that cause cardiogenic shock, dysrhythmias, we already talked about some the first hour, SVT, torsades, complete heart block. These are all causes. What's nice about these are that they're largely fixable by you. Right? You can fix any of these things in the back of your truck. So from a reversibility standpoint, great. The one that's a little bit less reversible is this type of cardiogenic shock, which is going to be cardiomyopathies. Again, cardiomyopathy is your nice umbrella term for something wrong with the heart. May not know what it is. Now, there are various forms of cardiomyopathies, like you have increased volume, so And what do you notice about, this is a normal heart, by the way. So what do you notice about the heart muscle here? It's stretched, it's thin, okay? So what kind of cardiomyopathy is this? Dilated cardiomyopathy. So when the heart kind of balloons out, the myocardium gets thin and weak, dilated cardiomyopathy. Here, we just talked about HOCM, hypertrophic cardiomyopathy. So the muscle is super thick, especially the septal wall is super thick, reduced volume, kind of backs up the pressure, causing atrial enlargement in some cases. So that's a hypertrophic cardiomyopathy. Here, the volume is actually normal. It's not any thicker. The heart thickness is relatively fine, but there's something wrong with the heart muscle itself. It's restrictive, like it won't contract as well. So that's a restricted cardiomyopathy or restrictive cardiomyopathy. And when you look at such things, like this is an example of HOCM. This is a, what are we looking at here on our ultrasound? So I kind of did a illustration of it next to it, okay? Remember, when we're looking at ultrasound, the heart's not right side up, it looks upside down to you from the ultrasound probe, but this is the conventional view of the heart, so you should recognize it. You recognize that this corresponds to this. The left ventricle, this is the right atrium, this is the aorta, the pulmonic arteries, okay, that you're seeing the exact same thing here. But if you look as it's squeezing, here's the interventricular septum we talked about that's so thick that as it squeezes, it's kind of choking its own outflow tract. You can kind of see it here almost where the walls almost touch each other there because it's so thick. And you can imagine that as that happens, you can see here that that outflow tract out into the aorta can get pinched off just because of how thick that septum is. And that's kind of what you're seeing here. It's squeezing pretty good. It's just that that interventricular septum is so hypertrophied that it's causing an obstruction. What does this one look like? First of all, is it squeezing very well? Not really, okay? Is the myocardial wall super thick and hypertrophied? No. It looks, if anything, a little thin. This is what dilated cardiomyopathy looks like on ultrasound, okay? So the dilated cardiomyopathy, it is barely squeezing, it's barely moving, and the ejection fraction is pretty cruddy, okay? So that's what that looks like. Here is an example of a restrictive cardiomyopathy. So the heart thickness looks relatively normal. It's squeezing, but it's not squeezing all the way. And you can see that it's just not, it's not a normal, healthy looking squeeze. And it just takes a lot of practice looking at normal ultrasounds as to what a normal ejection fraction or a normal squeeze looks like. This was easy because you could really tell that it was hardly squeezing at all. This one is squeezing, but you can see that it's just not all the way. The ventricular walls in restrictive cardiomyopathy are very thick, and so they're stiff, not as thick, but more stiff than thick, and so it just doesn't squeeze as well. So that's a restrictive cardiomyopathy. Now, there are other cardiomyopathies to include acute MIs, people that are having massive left ventricular MIs can also have acute ischemic cardiomyopathies. Right ventricular MIs also. Myocardial stunning, post-arrest. This is why that even if you get ROSC on a patient, you don't necessarily have to immediately give pressors if they're hypotensive because we know that they're just stunned a little bit. Give them a little time, give them a little bit of fluids, and their pressure will come up by itself. Anyone heard of neurogenic stunned myocardium? So neurogenic stunned myocardium happens with head bleeds a lot, or even big ischemic strokes. There's nothing wrong with the heart. It's just this weird connection between the brain and the myocardium, where a brain problem is causing what looks like a STEMI. But they take it to the cath lab and it's clean. Well, it's neurogenic stunned myocardium. Or somebody has a big basal ganglia bleed, pressure's 220, heart's not beating very well, and there's nothing wrong with it actually. It's just because of the brain emergency.
Is it the spike in ICP that?
That's one of the theories. But even where there may not be a spike in ICP, it's just because the brain is sick, there's obviously this connection that we don't always understand either, and it's causing the myocardium to be functioning abnormally because of the brain emergency.
And then on numerous occasions where it's a stroke and it also shows a STEMI.
Yeah. And they're not having a STEMI, it's just neurogenic stunned myocardium. Anyone heard of Takotsubo's? Takotsubo cardiomyopathy is literally a broken heart. Somebody receives horrible news that they just weren't expecting. They suddenly go into flash pulmonary edema or what seems like CHF when they don't have CHF. There's a very characteristic looking echo. It shows it here on the video clip. The basal segments contract well, but then you've got this mild mid-apical akinesis, and it looks like an octopus pot. Those pots that are used to catch them, because that apical akinesis, the heart doesn't move, but the basal segment is contracting, and so it has that characteristic finding, and that's from bad news. There actually have been a couple documented cases of someone receiving a really, really good news, and they were just so overwhelmed with the good news, they got Takotsubo's as well. Myocarditis can cause cardiomyopathies, and of course we did mention earlier ARVD, when the right ventricle gets replaced by fibrofatty tissue. That's also a type of cardiomyopathy. So all of these reasons for cardiomyopathies, and then there's mechanical reasons for cardiogenic shock. We haven't even talked about that yet, which is things like severe aortic insufficiency, severe mitral insufficiency, papillary muscle or chordae tendineae rupture. So remember what papillary muscles are? Those are those anchor points in the ventricle that hold those guide wires, or the chordae tendineae. You've seen those wires on these big radio antennas that go down to these big concrete blocks in the ground. Well, the concrete blocks are like your papillary muscles, and then the chordae tendineae are like those wires that hold the radio antenna up. Well, these chordae tendineae is what keeps the valves from becoming incompetent. So when the mitral valve slams shut, for example, it stops because the chordae tendineae keep them taut. If this were to rupture, if they had a major left ventricular MI, for example, and the muscle died, and you had a chordae tendineae rupture, suddenly you have severe and sudden mitral regurg. That can cause flash pulmonary edema as well. They need emergency surgery in that case. So these are all forms of examples of mechanical reasons why you go into cardiogenic shock. Regardless, these patients are going to be needed often to transfer to a higher level of care. That's where you come in. So when you've got these patients that need to be bridged from one facility to another very often, or even if they get to the destination, they just need a bridge to transplant or surgery, there are a number of things that the hospital can do to support them through this period of cardiogenic shock. So this kind of is a nice little graphic of everything from right ventricular support through both, like VA ECMO, to fully left ventricular support. Today, we're going to talk about Impella, balloon pump, and transvenous pacing. Just a brief review over each. Let's start with, we picked those three because this is what's commonly seen regionally for interfacility transport. So we'll start with Impella. Has any of you transported one before? A couple, three? Okay. So Impella is really a nifty gadget because unlike an LVAD, that needs a heart surgeon, sometimes a vascular surgeon, sometimes a thoracic surgeon, sometimes all three. And it's really done at only certain centers, like there is only one LVAD center in the region at Barnes. An Impella can be placed by anyone that knows how to do central line placements, essentially, through Seldinger technique. This is essentially a little motor for the heart that helps move blood forward, okay? And it is endovascularly placed up through the aorta, around the aortic arch, and guided directly into the left ventricle. So if you can run a central line, you can run an Impella. The Impella, the midpoint, sits, as you can see, right at the mitral valve. And as that little motor starts spinning, it ejects the blood up, forward, and out directly into the aorta at quite a impressive rate to augment forward flow. And that little motor, pretty powerful. It helps to increase coronary perfusion, but also helps to increase cardiac output. So it directly unloads the left ventricle. Typically because the left ventricle just doesn't have enough oomph to maintain cardiac output. So very, very relatively simple to place, much simpler than an LVAD to place, and it can be done endovascularly. So the cool thing is that Abiomed, the company that makes Impella, is very supportive of pre-hospital transport. I know that the Impella rep has been here at SCCAD before, probably been 2 or 3 years since they've been here. I want to bring them back sometime for one of our training sessions because it's always really good. They bring one, they show you how it works, and they show you how to troubleshoot it. But they also have this great website at heartrecovery.com that's free education, free training. And it talks about how to troubleshoot a lot of the alarms that you might see en route. Smaller hospitals are able to place Impellas as a bridge to get to an LVAD hospital, for example. And so when you do that, hopefully it'll be uneventful, but you might have some of the alarms on the console. For example, during transport, if an alarm occurs, there are some really basic things you can do to help troubleshoot. So one of the alarms that you might hear is the Impella position alarm. If the Impella position for some reason is detected to have shifted or is not right, one of the first things that the manufacturer suggests you do is just reduce the flow down to P2 because you need imaging to find out, did it go too far proximal or did it migrate distal? You don't know until you get imaging. The one thing they don't want you doing is messing with it. In the truck, you probably should not be pulling it back or pushing it forward because you don't have any idea where it's at. So the safest thing to do is just reduce the flow down to P2, drive a little faster, they'll get imaging to see where it's at. Okay? Suction alarm. Now this is something that's very satisfying because this is something that you may in fact be able to help with. A suction alarm means that for whatever reason, that motor is detecting some type of obstruction. A lot of times it's just because there's not enough volume. So one of the things that you can do, especially if the CVP is less than 10, and most of these patients will also have central venous pressure monitoring. CVP is less than 10 and you have a suction alarm, what should you do? Give volume. Give a 500 cc bolus, maybe even 1,000, depending on if they tolerate it, and that may resolve it. So that's one of the recommended actions as well from the manufacturer. Purge pressure low, check for leaks, loose connections within the system. Same with, if it's a purge pressure is high, look for kinks or obstructions in the system. If there's air in the purge system alarm, there actually is a little dextrose bag that they use to make this happen. And here actually is a picture of it. Here's where the dextrose line is. The yellow port is where that dextrose line should be. But watch for the head of the bed. The head of the bed should be less than 30 degrees. Look for bleeding site hematomas, bleeding like you would any central line placement. Monitor the catheter, the cables, purge tubing. Try not to pull, push, put any tension on any of the lines or kinks in the tube. And just monitor that way. And let the receiving hospital, of course, know if you have any problems. What's really convenient is, and if you want to take a picture of this, there's a nice little site that you can take this, that takes you to their, that this QR code takes you to, where you can download some of the manuals and the troubleshooting tips for an Impella machine. Okay, quick live quiz. During an inter-facility transport, your patient's Impella suction alarm sounds CVP is 9. You should. A, B, C, or D? You should. D. Good. Very good. Again, A is never the answer. We don't want you repositioning it en route. Okay. So yeah, give 500, give a liter crystalloid bolus IV. With an IABP, you've probably had more of these. Yes? Okay. So with the balloon pump, something that's really important to know about the balloon pump also is its placement. So typically, it is also placed ultrasound guided, identifying the femoral artery. And in figure C over there, you can see where they can identify that needle within the femoral artery. And they can thread that balloon, typically, ideally, between the takeoff of the left subclavian and the origins of the renal arteries. So that's where it should be placed. If it's below the level of the renal arteries or above the level of the subclavian, now you're obstructing flow to those two arteries, and that's never good. So it's got to be between those two. That's your markers. That's where it should be. It decreases demand, and it increases perfusion. Does someone want to tell me, how does it do that when the balloon is inflated or deflated? Does this, decreasing demand and increasing perfusion, happen during balloon inflation or balloon deflation? So I've got one person saying inflation, I've heard deflation. Which one is it?
Don't worry about me.
Decrease in the demand during deflation because the negative pressure from the deflation is pulling the blood out, so the hardest of the work is harder to eject it out.
All right, so nothing happens during inflation?
Inflation is whenever you're adding back pressure and it pushes back into the coronary arteries.
Very good. So my question was kind of a trick question. You're both right, because it happens during both. Okay, it happens during inflation of the balloon and deflation of the balloon. So when the balloon is inflated, like this shows, it is both. It's pushing blood forward, distally, but it's also pushing blood backwards towards the coronary arteries and increasing coronary perfusion pressure. Then when it deflates over here during systole, it's creating a net negative pressure and kind of acting like a little bit of a suction out of the left ventricle to decrease afterload and help forward flow. Make sense? So it does it both. It's really pretty nifty, actually. So when you look at it, timing is everything, right? Can you imagine if the balloon inflated during systole? That'd be bad. Or if it if the timing is off in any way, it's not optimal. The reason why this works really well is because notice, if you look really closely, just almost perfectly in sync here, this is what you're looking for. When the heart is squeezing, that sucker is also squeezing, closed. And when the heart is opening and relaxing, the balloon is also opening and being filled. Okay? So that, what ratio of counterpulsation is that? 1:1. Okay? That's full support. So there are times when, as they're being weaned off, they'll try to do a 2:1, maybe 3:1, of how they tolerate that, what their cardiac output is. But typically, when you're picking them up, they're on full support. It's 1-to-1 augmentation is what they call it. Okay? So during systole, it's going to deflate to create that suction, and during diastole, it's going to inflate. Forward flow is augmented, backwards flow is augmented. Now, in order for it to improve coronary perfusion pressure, what is assumed when it inflates? What anatomic structure has to be in place? Yeah, the aortic valve has to be intact, right? Because if there's a lot of regurg, well, now there's no back pressure against, because the heart receives its blood during diastole, unlike every other organ in the body. So if that aortic valve doesn't close, so that back pressure is now forced down the coronaries, then you don't have the advantage of increasing coronary perfusion pressure because there's no door to create that back pressure. Make sense? So that's why it's really important to have that. So I think I might have given away the answer. I did, dang it, I knew I shouldn't have asked that question. So a contraindication to balloon pump placement is D, right, is severe aortic valve regurgitation. Now notice that Neil Patrick Harris is saying why? 3 times he says why. So give me 3 reasons why aortic regurg, we already gave you 1, right? The one reason number 1 was a gimme, is because if you have aortic regurg, you can't get that back pressure to perfuse the coronaries. That's 1. What's the second why?
It's counterproductive and pushes blood back into the heart.
That's number 2. Counterproductive. Now you're basically forcing blood back into the left ventricle, and you're overloading the left ventricle, which is not what we want to do. Okay. What's number 3?
Lead the pulmonary edema.
I'd say
That's not wrong. Yeah. There's another reason. There's another reason specific to the balloon pump. What?
Renal perfusion or something? No.
No. Think about. Well, that's definitely a contraindication, yes. But why? You definitely don't want to put it in AAA for sure.
Your augmentations will be all like the.
Oh, you're really close. Augmentation. Yes, I'm impressed. I'm impressed. What did Andy just say? The third reason is
You won't have the diaphragm notch.
if you didn't hear what he said without a competent aortic valve, you lose the dicrotic notch. Now somebody tell me, not Andy, someone else tell me why does that make balloon pump timing errors, okay? Because what's the most common landmark for timing? The dicrotic notch. So, okay, I'm going to keep asking questions till I stump you.
Stump him. Yeah.
The dicrotic notch, okay, it assumes the transducer is where? In the right place, yes? Well, that's one of those guess what I'm thinking questions. Let me ask a better way. Is the transducer going to be in the aorta or in the femoral artery?
Oh, it's in the,
Oh, it
it's
should
in the aorta.
It's in the aorta, okay? Assuming you're transducer. So in other words, it is possible to have transduction or pressure wave transducers anywhere along that route. But the further away you get from the aorta, the further that dichrotic notch moves, and the less pronounced it becomes, to the point where once you get down to about the iliofemorals, you don't even have a dichrotic notch. Not because you don't have one, it's just because you're too far away for that pressure wave from the aortic valve slamming shut. And your time, yeah. So your timing gets moved proximal as your transducer does, because what you're measuring is a pressure wave. Does that make sense? And the amplitude of that pressure wave gets less and less to the point where you lose it the more distal you are from the valve. Cool stuff, right? So just remember that that was what you're assuming, and that's where most pressure wave transduction is done, at near the aortic arch, because that's what you're measuring. Okay, so in the aorta, you're looking for that pressure wave to give you the dichrotic notch, which is right here, which theoretically is because when that aortic valve slams shut in diastole, that back pressure kind of bounce is transmitted down to the transducer for just a millisecond, so you see that little dichrotic notch. So somebody tell me what we're looking at here. There's kind of a hint here. This is the patient's own unassisted normal waveform. Okay, so what happens to pressure during systole? Obviously, is going to go up until it begins to empty, and then as the volume goes propagated forward, that pressure is going to come down. Aortic valve slams shut. You get a little blip of a wave from that reflection of the wave down the vessel, and then your unassisted end diastolic pressure ends up here at this nadir point. So now that you know that the dichrotic notch is where your timing is how the balloon pump times the inflation and deflation, your systolic may actually fall, although the mean is going to be improved. That's the whole point. Okay? But you know that everything is timed right if augmented diastolic augmentation is higher than your systolic, and it should be. Your diastolic augmentation should be higher than your systolic. If it's not, something's off. Okay, so this is what that should look like. The shaded area under the curve represents diastolic augmentation. So as you're looking at this during your transport, you can see already where the dichrotic notch is, how diastolic augmentation is helping overall forward flow. It's decreasing workload of the heart, increasing coronary artery perfusion pressure. And again, this is temporary. People don't go home with a balloon pump. This is a bridge to whatever the hospital is going to do once they get to the hospital. So there are lots of alarms on these things. The three that I just wanted to review very quickly are the ones that, probably the more common ones that you're going to see. One is a low diastolic augmentation alarm. The second is a malfunctioning trigger alarm. And the third one is an autofill failure. So let's look at the first one real quick. The first one, if you now have a low diastolic augmentation, it is not higher than systolic. And you know that that's real because now your alarm is going off. Here are the things that you can at least look for. Number one is timing. Most common thing, timing. Is my timing off? Is there something making my timing off? The other one is, of course, leaks in the balloon. Whether it's gas fill, whether it's a hole, whatever. That would be another reason why it's not augmenting properly. So what are you going to do to check for that? yeah, you're going to look for signs of a leak. The most telltale one being like rust-colored flecks in the air tubing or even frank blood. That's not good, right? A leak in the gas circuit, get up, run the circuit, make sure there's nothing that got dislodged, nothing that got pulled off, nothing that's loose. There's no kinks in the line, nothing like that. The balloon not unwrapped completely, that's going to be a hospital problem. But I just want you to know that that is one thing, right? If that's the case, then the surgeon's going to have to do something with that balloon. The other one might just be they need a little bit of inotropic support. Because if the contractions of the heart, remember this is only augmenting, it's not squeezing the heart for the patient, it's simply augmenting what the patient's squeeze already is native. But if that squeeze isn't enough to clearly create a dicrotic notch, you're going to lose that, and that's going to affect number one, inflation and deflation timing. So there are some cases where they need a little bit of positive inotrope, and then that might in fact help with also contractility and help the machine see the timing better.
Is that why the pitch for the Impella that they'll eventually phase out the balloon pump?
I think it's for a couple reasons. One, because it's a lot easier to place. But two, because the Impella is actually augmenting the heart's function and directly offloading the left ventricle. And everyone knows how to put central lines in under cellular technique. So the muscle memory wise, it's very comfortable for most practitioners.
For your positive inotropes, Devo or dobutamine preferably?
Probably Levofed, maybe even Epidrips. Now, here's a favorite test question. Is dobutamine considered a pressor? So dobutamine more affects squeeze. It's going to improve contractility. Now, it may make your blood pressure go up, but not because it's a pressor. It doesn't cause vasoconstriction. It improves contractility. So by doing that, it may inadvertently improve blood pressure, but you don't consider it a pressor like vasopressin or phenylephrine, for example, or neosynephrine, okay, a neostick. Those are pressors. Dobutamine is a positive squeeze. Improves contractility, so remember that. The other thing is dysrhythmias. You can imagine that if your patient all of a sudden goes into AFib or VTAC, that your IBP is going to not work as effectively. So sometimes, if they go into a dysrhythmia, atrial fib, pretty common, then what you're going to want to do is address that. And that may help that alarm go off if you can then improve the time. It all goes back, a lot of it goes back to number one, which is timing problems. Now, trigger failure is also often because, besides loss of the dicrotic notch, maybe your electrodes are off. Something as simple as making sure that every electrode is still picking up. It's the fundamentals, right? Like the first time we talked, getting back to just basics. Like all the fancy stuff is great, but just think about the fundamentals. Where are my electrodes? Are my cables connected? Cables squashed underneath the wheel someplace? Maybe all you need to do is increase the voltage on the cardiac monitor so that it can be picked up a little bit easier. What if someone has a pericardial effusion? What does that do to voltage? Makes it small, okay? But you all know how to select voltage and increase it, right? So that it's easier for the machine to see. So maybe you need to do that. Look for faulty cables. We mentioned dysrhythmias already. Maybe there's some electrical interference. Maybe they have a nerve stimulator. Maybe they have a TENS unit, I don't know, something that's causing electrical interference, so think about that. Now, You may, in some cases, need to switch to an arterial pressure trigger. That is an option. I honestly haven't seen that very often.
Fiber optic now, right?
I don't know, actually.
I'm pretty sure the ones we have, if you take the electrodes off, they'll switch to fiber optic, which is essentially a pressure, but it's going off of
The light,
so we don't hang a pressure bag anymore. It'll just do.
that's great. Yeah. If that's going to be easier to do, maybe just do that. You know. The point is, if you have an option, use that option. You know. So the other one is the autofill feature, and that is what this refers to is it is what keeps the gas. It maintains the volume of gas within the balloon. So if you check the gas level of the tank, make sure there's no gas outlet, occlusion, or obstruction. Again, fundamentals, easy fixes, easy things to do to make sure see if that fixed the alarm and go from there. Another quick live quiz. If you notice blood in the air tubing, you should immediately, A, stop anticoagulants, B, check the pressure and manage hypotension if they're hypotensive, C, switch from 1-to-1 to 3-to-1 augmentation, at least, or D, pause the IABP and notify the receiving facility. That was pretty fast. I think I heard all of you say D pretty quickly, and yeah, the answer is D. Because what are we seeing? And what if you don't turn the machine off? You're pumping air. Yeah, you're pumping helium into the aorta. That's bad, okay? So don't do that. Yeah, and I would notify the receiving facility immediately. Say, hey, I think I've got a balloon rupture, and I'm coming in for a hot extract with y'all. So let them know. Transvenous pacers. Transvenous pacemakers are good bridges, typically placed in an emergency department acutely for someone who's decompensating, and then they're going to need to go to a bigger facility for either, they're going to need a permanent pacemaker or some other, whatever's causing the symptomatic bradycardia. Lots of reasons for people to be weak and dizzy all over. Lots of reasons for them to need emergent transvenous pacers in the emergency department. What you're going to do, of course, on scene typically is put TCP or try that, and if that works, fantastic. But if it doesn't, and frankly, even if it does, what are they going to get in the emergency department if they can't get to the cath lab immediately? A transvenous pacemaker. So have any of you seen one being placed? Okay, good. So lots of things can cause severe bradycardia. What are we looking at up there on the strip? There should be enough information that you can make a diagnosis. You sure it's not Winky Bach? You should have enough information there.
There's a P wave between the QRS and the T wave, so that one would be Winky Bar.
Right. You're right, it's third degree. So the P waves are all going out, but they're not at all in relation to the QRS complexes. So yeah, you're looking at third degree block. So that's one of the most common reasons for someone to get, especially if they're hemodynamically unstable, they're going to need transvenous pacing. So sometimes cardiotoxicity from a drug overdose can do the same thing. Whatever the cause of them getting a pacemaker, they're going to get. You can float it in through a number of ways. Which side is the most common? Right IJ. Why? It's a straight. Nothing more than it's easier. You know, I could put it through the left subclavian, but why on earth would I want to try to make two 90-degree turns? I can go straight down. It's a straight shot to the right ventricle, to the right AJ. So all things being equal, I'm going to choose right AJ all the time. So here's the stuff. Can you tell me what all the parts are? Very good. I tell you. Erica is just genius. Yeah. Very good. So yeah, they're all labeled, of course, but why would you use an alligator clamp?
Because they
They all got all empty.
You don't want it to pull everything out, you want it to be able to separate.
You could use it for that.
Or stop the bleeding.
Yeah. So, I'll show you on the next picture what you can do with that. But here, you're just seeing the basic parts of what you're going to need. You're going to need a pacer box. That's going to what's delivering the energy. You're going to. This is the part that actually goes into the heart itself. These are all little markers that tell you depth of placement. One of the biggest mistakes is forgetting to put the sterile sleeve on before you start putting it in, because once you're threading it in, you can't put the sleeve on. So you put the sleeve on. You can leave it all scrunched up like that, but just thread it on, lock it in place, and then once you are at depth, you can extend that sleeve to protect it. The sheath introducer is what this is going to go through once you get the IJ placed. These adapter pins are going to go into these ports here that gets plugged into the connecting cable that gets plugged into the pacemaker box. The syringe is going to be for your balloon. I'll tell you what that does in a second. But the alligator clip, if you don't want to plug both ends into the connecting cable right off and just use capture on your monitor as evidence that you're in the right place, what some people do is they'll instead take the V1 lead of an EKG onto the distal or negative lead. Instead of plugging that into the box, they'll put the alligator clip on the end and plug that in to the V1 lead, and instead, as they're threading it, they'll watch the V1 on the monitor until they start to see the QRS complex. And then they know, okay, that's where I am, and then they'll plug it into the box and turn the box on. It's all preference of operator preference. One's way is not better than the other, but that's why they have it in these kits, just in case you were wondering, why do some people use it, why do some not? That's why. The balloon. Why would we have a balloon on the end of this thing? Is that to hold it in place, or is there another reason? What? Someone said it float. Yes, it's basically like a Swan-Ganz sail. In fact, that is how Dr. Swan came up with the idea for floating a Swan-Ganz catheter. Did you ever know that? He was sitting on a hill one day watching a boat on a lake. The boat put its sail up and the wind caught it and it just went off. And he says, And that's how he got the idea of putting a balloon at the end of his catheter, because he was trying to figure out, how am I going to float this in? He said, well, I can make a balloon and it acts like a sail. It'll catch the blood flow and help do pulmonary capillary wedge pressure, stuff like that, help it turn the corner. Very genius. So same kind of idea. Once you're in the vessel, you can inflate the balloon. It helps take it through the right atrium into the right ventricle. Easy. So once you are ready to place this, most places now will use ultrasound-guided localization of the right internal jugular and place it that way. I still think it's important to know your landmarks anyway, but for placement of a transvenous pacer, you'll need to know where the IJ is in relation to the carotid pulsation, because you don't want to stick it in the carotid, for one thing. The other is the triangle that's formed by the sternal head and the clavicular head of the sternocleidomastoid forms that triangle with the clavicle at the base. And at the top of the triangle right there, that's what that little star means. That's typically where the IJ travels through. What you're also doing, you're feeling for the carotid artery pulsation, and you always have to go lateral to it. And that way you're not going to puncture the carotid artery. But finding the carotid pulsation, going lateral, and finding it at the top of that triangle is the best way to know where you're going to put your needle. You're then going to take that needle and point it towards the ipsilateral nipple line and withdraw on that syringe until you get a flash, and then you know you're in the IJ. Thread your wire, et cetera, to put your introducer in, and then put your transvenous pacer through that introducer. So just like putting a central line in, except instead of putting a line, you're putting a transducer cable, a pacer cable rather, through that introducer. Now, the thing to recall is that there's a lot of important structures when this is being placed. So one of the most important things for critical care paramedics to do when transporting a patient who just had a procedure, I don't care what the procedure is, but especially a transvenous pacemaker placement, you got to know how it's done and therefore what the complications are, because the doctor who did the procedure may not realize the complication until you've left already, or the complication may not develop until you're on the road. So you really kind of know, need to know how this is placed and what the complications can be. So it's not that the carotid artery is lateral per se and separate from the IJ. It's actually right behind it. Okay, I know this picture made it seem like the carotid is, 3 centimeters away, but that's not the case. In real life, it's just below it. So when you're feeling the carotid pulse, you know that just lateral to it is where your IJ is, and you don't want to just, the reason why you're pointing towards the ipsilateral nipple is because if you point it medially, there's a very good chance that you're going to go right through the carotid. So if you're pointing this way, if you do go through the back wall of the IJ, you shouldn't hit the carotid. That's the hope. That's the whole purpose of pointing it towards the ipsilateral side, the ipsilateral nipple. The other thing to remind you is that look where the vessels are. Look how long that needle is. Can I convince you that if you happen to back wall that thing as you're placing it, you might hit an important structure behind it? And I put this picture up there to kind of give you a clue what structure I'm talking about. What am I talking about? The what? The lung. So if you put enough central lines in, especially subclavians, but including IJs, you'll eventually cause a pneumo. Just if you've never caused a pneumo, putting these lines in, that tells me you haven't put enough of these in. Okay, so eventually that's going to happen, because look, people think that the lung ends below the clavicle. It does. It actually goes above the clavicle. So it is quite possible to puncture the pleura and cause a small pneumo. If this patient happens to be intubated, that's not so good, because now you got positive pressure and you'll definitely get a pneumo. Okay, so sometimes it'll be small enough if they're not intubated that you just give them some oxygen, they're fine. Nothing happens, but just be aware of that. So that's essentially what it's going to look like once you get that wire passed down the IJ, right atrium, right ventricle. You want it to lodge right there at the bottom of the right ventricle. You don't want to push too hard, because what could you do? Puncture the ventricle as well, and that's also suboptimal. So try not to do that. This is what it looks like on an X-ray. It is radio opaque, so that you should be able to see it. If you have opportunity to review the X-ray before you leave with the patient, that's also a bonus. But that's the line coming through the IJ, through the right atrium, and lodge here at the bottom at the ventricular apex. So, complications. The complications include, like any central vascular access procedure, bleeding, infection, pneumothorax, but ventricular injury and pericardial tamponade. This is something, and that's probably the one that you really have to watch out for, because even on an X-ray, the doctor may not see that. And it may not be evident. If it's a small puncture, the tamponade may develop over an hour, and it's only when the patient is with you and you're halfway down to the university on Highway 40 or I-70 someplace that they start developing tamponade physiology. You got to think, hey, he just had this placed and he's showing signs of tamponade. What could be happening? You got to think about ventricular injury. Okay. I would hope that a pneumo, and pretty much every time a central line is placed, before a patient gets transported, they will do an x-ray to make sure there's no obvious pneumothorax. And that is something that they should catch, hopefully, before you take off with the patient. But a small ventricular injury you may not be evident until you're well down the road and you've left. So keep an eye out for that. Infection is not a problem you're going to see in the back of your truck, but that may be something that's going to happen later on in the course of their hospitalization. Okay. During an IFT, the Impella position in aorta alarm sounds. You should, very good, you should see. What is the first thing that they're going to have to do when they get to the receiving facility? Check placement. And that's something that they'll do well after you get them delivered. How about this one? Shortly after going into AFib, your patient's IABP alarm for low diastolic augmentation sounds. You should administer I've heard A, I've heard C, I've heard B. Someone just say D, so we've said them all. I'm kidding.
I see them do B.
So the stem of the question, I was hoping the stem of the question would suggest that they were in normal sinus rhythm and everything was hunky-dory, and then they all of a sudden went to an AFib in front of you. So it's not like chronic AFib.
So C.
I was, maybe this is not a good cut. I was hoping you would say A, because if you can get them back into a normal, if you convert them back into normal sinus rhythm, then the dicrotic notch comes back on and the timing gets better, augmentation is more consistent, and then that alarm goes away. I wouldn't necessarily pause it though, but.
I wouldn't do this, but what would happen if you synchronized cardioverter with the balloon pump going?
Actually,
Oh, huh.
it's an anti-dysrhythmic.
That electric synchronized cardioversion is an antidysrhythmic. You're right. You could probably do that. Probably, assuming that they're otherwise stable, I'll try the antidysrhythmic first. You're braver than I am. No. All right. Question number 3. A local ER puts a transvenous pacer in, the right IJ, quickly initiates a transfer. Get this patient out of my emergency department. They're intubated, they're sedated. En route, they become hypotensive. Your first action should be
Probably punctured the, or they got
At least invasive first.
No problem. That's where it's
Later.
easiest.
Oh yeah, make sure it's working.
That's what I.
First, he could be hypotensive from the, if the pacemaker stopped working, it would be hypotensive.
Okay, it was late at night when I wrote this question, so clear, bad stem. What if I said, en route, the patient becomes hypotensive, the peak airway pressure alarm is also up and sounding, and okay. Well, see, if I put that, it was too obvious, so.
But if the pacemaker stopped working, he'd be hypotensive.
No, you're right. I should have given you more information in the stem. Okay. I should have added pacemaker spikes are still being seen on the monitor. Peak airway pressure alarm is on, and they're hypotensive. Okay, now what would you do? Okay, that's what I was going for. So, because going back to known complications, they very well could have developed a pneumothorax because they could have punctured the pleura. They're intubated, so they're in positive pressure ventilation. So that's kind of what I was going for. But you're absolutely right. I didn't give you enough information in the stem, so better stem next time, or don't write questions in the middle of the night. But yes, so I definitely don't want to just increase the pacer rate. That's not that's not your first action. Push dose pressure is definitely not your first action regardless. But I could see how A or C could have been the right answer. So I gave you a little more. Y'all chose C. That's what I was going for. So regardless of what, one of the take-home messages I wanted for this particular question was, you're a critical care paramedic. It doesn't matter that we happen to be in the cardiac module today, airway last time we talked, or whatever. If you have an intubated, sedated patient who then crashes, the first thing I want you to do, all things being equal, is dope. Off vent, on bag, squeeze. That is your immediate action drill. Crashing a patient on a vent, off vent, on bag, squeeze. Because in that 3 to 5 seconds, you can tell a lot. Because if they're off the vent, on the bag, squeeze, and it's easy to squeeze, well, it's probably not a tension pneumo. It's probably not a big loogie in the tube either, okay? But if it's off vent, on bag, squeeze, and they're like, wow, it's kind of hard to bag, now you're thinking tension pneumo or giant mucus loogie in the tube, something, both of which you can fix, which is great. But you can tell a lot just by doing that alone. So dislodgement, obstruction, pneumo, equipment failure. E would definitely be, is the pacer box working? The batteries, is it on? Batteries didn't go dead, which it very well could have. One of those leads get pulled out of the pacer box, it's not connected anymore. E for equipment failure for sure. But DOPE, certainly for any patient that starts to crash when they're intubated. That's what I worry about. Very good. So, to kind of wrap up what we talked about today, shock, hypoxia at the cellular level. Cardiogenic, just one of the 4 broad types. EMS will manage bridge therapies like Impella, balloon pump, pacemakers. Regular refreshers and awareness of these evolving therapies is really fundamental, which is why I'm going to try to get some of these latest advances and updates to these machines that bring the reps in to actually do some hands-on stuff to mess with these machines, and see how the equipment has changed and how we in EMS can better troubleshoot these things. I think that'll be a lot more fun, and something we'll try to do in the future is do a hands-on piece.